Hello and welcome to RSM Live. My name is Libby Haxby and I'm the current President of the Patient Safety Section of the Royal Society of Medicine. I'm delighted to welcome you to this webinar, Reflections on Patient Safety from the Nightingale Hospital. Before I introduce our guests, I need to go through some housekeeping. We're aiming to run for about 45 minutes with a little leeway at the end if there are lots of questions. Following a brief introduction, each speaker will deliver their talk or presentation sequentially, and then we'll facilitate Q&A as a panel at the end. Please ask your questions via the Q&A function, and we'll do our best to direct them to the relevant speaker. This event is being recorded, and we will email the link, video link to all delegates, and it will be available for up to 30 days. The Nightingale Hospital, so called because the design model was commissioned by NHS England on the 23rd of March to take up to 4,000 ventilated patients with COVID-19 at a time when the full potential impact of the pandemic was uncertain. It opened at the Excel Centre in East London on the 3rd of April and the first patients were admitted on the 7th. The building of a healthcare facility of this scale in such a short time period offers significant and unique challenges, not least in relation to patient and staff safety. I'm pleased to welcome 3 healthcare professionals who are directly involved, either in development of the safety system at the Nightingale or who contributed to it when delivering care at the bedside. Without further ado, I'm pleased to welcome Dr. Andrew Wragg, who's a consultant cardiologist and the Director of Quality and Safety at St. Bartholomew's Hospital, as well as being the Deputy Medical Director at the Nightingale Hospital in London. Thank you, Andrew.
Thank you very much for inviting me to join this webinar. And I think before I get into the detail of talking about the Nightingale Hospital, it'd be quite nice just to put into context a little bit what was happening across the whole of the NHS. So although today we're going to focus on safety aspects of the very unique nature of the Nightingale, many of the things that were happening there were also happening across all NHS organisations and indeed across all healthcare delivery systems throughout the world. And that essentially meant that we were all having to learn how to manage a completely new disease. Staff were having to be redeployed into areas they weren't familiar with working in, and also to be trained to do skills and tasks that were really outside of their normal job description. So many of the principles of the approach that we took were the same across the NHS, and actually pretty much all of the hospitals across the UK have successfully risen to the challenge. However, at the Nightingale Hospital, there were some specific things that were quite unique, and they're mainly focused around the kind of the geography and the infrastructure of the building. So in the upper slide, you can see an aerial photograph of the Excel Centre. And the reason we had to go there was because it was probably the only place in London that had the capacity to house a facility of the numbers that Libby mentioned, of potentially up to 4,000 patients needing ICU support. And the problem we had was that the Nightingale Hospital essentially wasn't a hospital at all, it was a conference centre. And it wasn't just it was physically isolated, but to begin with, it wasn't actually part of any conventional NHS or healthcare institution. And therefore, if you look at the bottom picture, we had to convert both of these huge halls that make up the conference centre into a large-scale ICU facility at an incredibly short space of time. Although there's a great focus on the clinical care that was delivered and people involved in clinical care, it's really important to acknowledge that actually there was a really great team of people that actually did the initial build and planning of the hospital. I think it's well known that the military were involved, and it was a fantastic experience working with the military and utilising their expertise at this type of problem. But not only were the military there, but we had engineers and architects and also all of the contractors who actually built the infrastructure of the hospital, that was overseen by some exceptional NHS managers and clinical leaders. And I think it was, a really great team effort that allowed the hospital to be literally physically built and also brought into operational delivery over such a short space of time. This is the kind of blueprint map of what the hospital looked like. And essentially, it's just to give you a bit of an example of the scale of the problem of housing and managing so many patients. The Excel Centre is divided into 2 main areas, or 2 halls as they were called, north and south. And assuming that the modelling was correct, we were going to have to accommodate many thousands of patients potentially. So on each side of the centre, in each hall, there are 40 wards, we call them, and each ward would potentially house up to 42 patients who are all going to be ventilated ICU patients, so really critically ill. And this was a really unique project. No one in the world had ever tried to build an ICU unit of this scale or size. And fortunately, I think as everybody's aware, we didn't have to use it. And that really was a credit to the great work that people in London did with regard to following the rules of lockdown and avoided the super surge having to have so many patients looked after. So actually, within essentially just over a week, we'd actually managed to build an ICU in a conference centre. And although it was a very strange environment, actually, we and actually many visitors who came to look around felt we'd had delivered a very good ICU in that infrastructure. It was a very surreal experience working there because of the scale. It felt like slightly being in a dystopian novel. This is just one ward. We only actually opened one ward. But if you can imagine that as you walk into your area, you pass row after row of empty wards with empty beds. And you can just imagine the kind of the anxiety that all of the staff, both the people working clinically and helping to run the hospital, felt with the responsibilities that we had if the patients were going to keep coming. So it's important that we just kind of define some of the key metrics about the hospital. Still today, clinicians even ask me, did we actually have any patients? And indeed we did. We were clinically open for 29 days, predominantly through the month of April. We did have a capacity of physically built bed spaces of up to 3,600 patients. But fortunately, we only had to open a maximum of 34 beds concurrently, and we treated a total of 54 patients. You may argue that 54 doesn't sound that many, but actually in conventional ICU terms, that was still a significant ICU, and that was still a significant amount of critically ill patients that we cared for. We also had to assimilate and train many staff to help us work in this unit. And there were many thousands of staff who we boarded and registered potentially to work. But over 2,000, though, were trained through our really amazing training program, which was run out of the O2 Arena. And of those, just over 700 actually worked a clinical shift within the unit. So getting on specifically to patient safety, what do I consider were the main aspects that kind of helped us be safe? And indeed we were safe. And I think really probably 90% plus of it was all really around the people who work there. It was both personally and professionally an incredible experience working there, mainly because of the amazing staff and colleagues who were very much focused on the responsibilities of what we had to do and deliver. The examples of every team, both big teams and small teams, working in a multi-professional way to solve problems, to rapidly improve, to learn, to improve the safety and also the quality of the care we gave was really exemplary. And actually, whether it be actual individual members of staff working in the clinical area or even clinical leaders or managers, everybody rose the challenge. And that was across all professional groups. And it was a really refreshing experience to work in such a dynamic environment with such a great group of people. I'd love to say that we were all exceptional and actually we were a unique example of what the NHS can do. But I think actually the Nightingale really was just one example of what the NHS can and did deliver across all hospitals. I'm quite involved in quality and safety back at Barts Health, which is a very large trust with many acute hospitals. And actually now I've returned back to my normal job, I've been really impressed about how all of the hospitals in our network did pretty similar things very safely with really good outcomes for their patients. And I think Nightingale is just an example of what all of the NHS staff have done and are able to do when asked to. However, I think we also benefited as a hospital because we had a very clear specific mission. And that was essentially, we knew we had to save lives of Londoners who might need ICU support. We also had to really focus on keeping our staff healthy and safe. That was fundamentally important to running and sustaining a safe service. And we were also absolutely focused on the support of our families. I mean, compassionate care was one of the really, really big focuses of our work. And a lot of effort and resource was put into delivering what we thought was really great exemplary care of looking after the families and relatives of the patients who were looking after. Not only they were going through the pandemic and suffering from a terrible illness, but we recognised the stress families would be under by being transferred to quite an unfamiliar environment without any certainty of the kind of care that they'd be receiving in our facility. We also recognised from day one that we just had to be a learning hospital. I don't think this was some luxury. We were not a hospital to begin with. We had not tested any of our systems and processes. We really didn't know whether we were going to be able to deliver a reasonable set of outcomes, and that really meant whether our patients would have acceptable mortality from being looked after at our hospital. And we just had to learn very quickly. We were very lucky that right from the beginning we developed a quality and learning team. And we had some really kind of global experts who are specialists in innovation and improvement, with really strong clinical governance embedded in part of that. We worked very closely with, again, a super team of educationalists and training experts, and they were able to deliver probably what I think is one of the kind of the best and most focused induction and training programs for that any hospital could hope to deliver. And they delivered this at mass and at scale, and were also really reactive to any problems that came up. For example, if there was a safety concern raised on a Monday, often by the Tuesday, we would have the learning required around the issue fed into the training of new staff coming on board. We also benefited from a really flat hierarchy, and I think all staff who work there kind of comment on that. I'd like to say that that was really kind of intentionally and through design, but actually we didn't have any choice because we had to develop, build and offer care at such a quick pace. The conventional process of layered decision-making that organisations would have was never going to work. And a good example of this was our change forum that we evolved. So every day at 4 o'clock, we had a structured meeting whereby every team was represented in a large, big open planned part of the Excel Centre, where we'll be able to share the problems of the day, raise all our issues that we weren't able to fix, but also we empowered every individual member of staff to take responsibility for just solving and getting on with their problems and then sharing them with the wider group in the hospital. And this allowed us to improve really quickly, to identify problems that were important rapidly, and also solve these problems without having to go through more cumbersome processes. I do know very similar things were done like this across all hospitals, but actually we kind of really embedded this into the management structure of the hospital. And it's fair to say that this kind of clinically led change forum really was the management process structure of how we run the whole of the Nightingale Hospital. So what do we do about governance systems? So we did think for the first few days before we opened, could we kind of bypass and have really light governance systems? But actually, the more we thought about it and the more we worried about whether we could we even deliver high quality and safe care, I think everyone involved realised that there could be no compromise around our clinical governance approach. And so therefore we had Datix embedded and ready to go from day one. Datix is one of the most widely used data systems that monitor clinical safety problems and issues within a hospital, and certainly most NHS staff are familiar with it. We'd agreed that we couldn't compromise on any of our governance approaches, but we also realised that we couldn't perhaps have some of the more unwieldy, timely investigations and systems that just wouldn't be fit for purpose in a hospital like the Nightingale. So we recognised we would need lots of pathways, but they had to be very focused on the environment. So we developed a very short but effective serious incident pathway for if we were to have serious incidents. We fully committed to the responsibilities of following duty of candour, which we always did, and all of our families were fully informed of everything that happened to their patients, and particularly around any safety problem or incident. We had a clear, very reactive complaints policy, which we used. And we also developed a really strong learning from deaths system, which we're very proud of. So we had multiple tiers from structured M&M through independent review of every patient that died by a pathologist, a bit like the medical examiner's approach. And we had really structured learning from deaths so that any improvements could be fed back in to the care that we gave. We also recognised that this was kind of one of the few places where you absolutely had to have really strong clinical audit. We could not assume that the care we give was going to be of an acceptable standard. And so again, from day one, every and indeed all of our patients were recruited into the National ICNARC audit, which is the ICU national audit, and has become the main way of auditing the outcomes of patients with COVID who were admitted to ICU. We also recognised that we need to develop really good reference guides, and these were used extensively by staff, and indeed the quick reference guide handbook we had has been widely shared with other organisations. We also had to really develop incident management. We did think about could we have a different way of collecting incidents, but we had to collect the intelligence about what was happening, particularly around patient safety. So we developed a novel role called the Bedside Learning Coordinator. This individual had a number of responsibilities, but one of the main focuses of their job was actually to pull incidents around patient safety from the staff during a shift. So on every shift, we had a bedside learning coordinator whose job it was to speak to all staff during a shift, identify problems, record them on Datix. Every day we had a team of governance people, senior nurses, clinical leaders who would then review every incident and manage them in real time. And that was a really effective way of getting on top of all of our issues that we knew we would have, but being able to manage them very quickly and effectively so that we could learn. We did have 2 serious incidents and commissioned 2 investigations. And actually the process we developed worked really well. The investigations were generally almost fully complete within 48 hours. And literally by 7 days, all of the actions had not only been defined, but actually we didn't not only embedded them, but we'd also done some bedside audits to confirm that they were already in place, proving that we'd had this really effective learning system that was working to constantly improve the quality and also the safety of the hospital. And actually, by the time we got established, you know, I feel and others that we'd actually developed a pretty good, strong safety culture. And actually, our very high levels of incident reporting are kind of a good evidence of that strong safety culture. So finally, I think we just need to talk about the risk of the whole project. And actually, for all of us who are involved in it, many of us, for most of the time it was open, didn't sleep much at night because we recognised this was a really risky business, not both from a patient safety perspective, but also just operationally. For us to be able to stay open, to deliver care, to have all our pathways working in order to support and look after sick London patients, there was a lot of risk around this. So we employed and brought in a really experienced full-time risk manager who one of the first things they did was help us define what is our risk appetite. And actually, were we prepared to accept perhaps lower outcomes or an unsafe environment? And actually, everybody who worked there really did not want to work in an unsafe hospital. And so we set our appetite as being low for risk around safety and low for risk around quality. And then when we logged all these well over 100 clinical risks, some of them eye-wateringly high to begin with, as we grappled with developing our operational problems, we knew we had to manage these risks down, either mitigate them or solve them as quickly as possible. And actually, over the course of the month we were open, you know, I was really comfortable that all of our very high, over 20 risks that we had were all managed down to an acceptable level and almost to an acceptable level of conventional clinical care within the NHS in non-COVID times. So I think the whole way we used risk and how we embedded it in our systems was really helping, not only just helping us improve, but it also gave the security for the staff working there that actually we were aware that this was risky and that you're concerned and worried. But as an organisation, we've clearly defined that and we know where we have to improve. And I think that was a very positive part of helping us deliver safe care. So as I think we all know, the Nightingale Hospital is now closed. It's empty of patients. But it's ready. NHS England is still defining the exact detail of how it's going to remain in a state of readiness. But I think it's really important that the NHS, for referring hospitals and their clinicians who work there, and also very importantly for the public on potentially future families of patients that may have to go to a facility like the Nightingale Hospital, that they're aware that actually the project was very successful. It stood up to what it was asked to do. Fortunately, it didn't have to go to the scale, but we proved that you can deliver complex intensive care in a very difficult environment, and you can actually do it with reasonable outcomes. The final audit data is still awaited. There's still 20 of our 54 patients are still in hospital across London, but we delivered it safely. And I think knowing that is very reassuring, because if we ever did have to open the Nightingale Hospital again, we actually know that the system can deliver a good level of care for the patients that might come there. So at that point, I will now stop, and I'd like to hand over to my 2 colleagues who are going to talk a little bit about their experiences. Thank you.
Thank you, Andrew. Thank you for setting the scene at Nightingale and for talking about how you adapted recognised NHS safety systems for the task that you faced, and how you did it so thoroughly and built an infrastructure so quickly. I'm now going to ask Jonathan Behar, who's a Locum Consultant Cardiologist and electrophysiologist at the Royal Brompton and Harefield hospitals to talk. He has a PhD in image guidance cardiac device therapy, but as the wave of COVID-19 hit the UK, he volunteered to work as an intensive care doctor at the NHS Nightingale Hospital. So thank you, Jonathan.
Thank you very much, Libby. First of all, can you hear me, and can you see me, and can you see the slides?
Yes, to all of those.
Okay, very good. So thank you very much for the invitation, and thank you to the RSM for hosting this webinar as well. I'm by trade a heart rhythm doctor, as you mentioned, and I usually work at the Brompton and Harefield, and was going about my business as was everyone else at the beginning part of this year. And then as elective activity certainly ground to a halt, I volunteered to be part of the team at Nightingale, and it was a really humbling and fantastic experience, which I will always remember. So, as you've already heard from Andrew, it was built in a very short space of time and with exceptional assistance from the military, and was in essentially a large convention centre constructed in the best part of a couple of weeks. And what I thought I'd do is I'd just talk through some of the challenges faced, but firstly just talk about the overview of a shift, really. And this is an overview of the venue. You can see that there's two large halls separated by a gangway in the middle, and one would collect the scrubs from the west entrance here down at the bottom, and walk what is the best part of a kilometre up towards the east entrance here, where the shift would start in the clinical area. You can see that there's areas in the middle for pharmacy. There was an important space for staff wellbeing, which Johanna will come on to talk about, and there were areas where equipment was situated in the middle. And I think it would be fair to say that going into work on that first shift was quite scary and filled with a lot of trepidation for many of us. And there's of course many challenges working in PPE, and those are faced by colleagues up and down the country, not just at the Nightingale. I think there were some quite specific challenges at Nightingale, which were mainly due to the unfamiliar environment and setting that we were in. The large nature of the hall and the enormity and scale of everything was really quite overwhelming. In addition, we were put together in teams of doctors, nurses, allied healthcare professionals, biomedical scientists, and critically, we all came from different hospitals, so we all had experiences of different practices and protocols. Equipment such as infusion pumps and ventilators may have been different to all of us, and so we were working with equipment and people that we weren't used to working with. And I think another really important feature is that a large number of us were not intensivists. So of course it's important to state that the supervision, the running of the unit was done by highly expert intensive care specialists. But a large number of us who were helping and assisting were not used to that intensive care environment. But that didn't really matter in the sense of the fact that we were there to provide our expert help and treat patients and care for patients and try to save as many lives as possible. And I think that this quote from one of the doctors in Bergamo in Italy that faced a real tsunami of COVID at the early part of the year summarized it quite nicely. It really didn't matter what type of doctor you were, an eye surgeon, a cardiologist. We were all there as one part of a big team. And I think what was really remarkable was the sheer ability of individuals to be flexible and work in a very unfamiliar and unfamiliar clinical setting. And so there were consultants of many years standing working as ward doctors. And I think that's testament to the flexibility and fantastic nature of the team that we had. So the other thing that was really important is the selection and use of guidelines and protocols, and this online learning platform we shared was used really to a large degree by a large number of people during the time that Nightingale was open. And in addition, the quick reference guide that Andrew mentioned, again, these were present at every bedside. And it's important to state that as individuals, we came from different areas. We didn't know the equipment we'd be working with. So it was really important to have quick step guides about how to use certain equipment, how to follow certain protocols, and to be all singing effectively from one hymn sheet. And I think that this really impacts upon patient safety and ensuring good quality care by making sure that everyone was versed in the protocols and the different types of equipment and the processes involved, as they were new to everyone. Another challenge really, of course, shared by colleagues who are in PPE now up and down the country is that of personal protective equipment. Clearly, the main thing, I think, for me and for a lot of colleagues is really communication. And of course, when most of your face is covered and you can only see someone's eyes and their name across the visor at the top, it becomes very challenging to communicate. And it made me personally realize how important nonverbal communication is. And the facial expression that we rely upon simply was not there when relaying information from one person to another. So like many others, we used and employed hand signals, and at times you needed to shout to ensure the information was understood. And I remember being involved in a cardiac arrest situation and how challenging it was to ensure that team roles were communicated effectively between individuals, because the sheer nature of the PPE made it really, really challenging. And as a result of all the walking involved, it was, of course, very easy to become dehydrated, as this slide nicely depicts. Clearly, during a shift of 12, 13 hours, we would need to take breaks to ensure that we were well hydrated. But it was particularly challenging. And I think ensuring that we were all well hydrated and well looked after was a big part of the fabric of the organisation and the wellbeing team, which was really, really critical because, of course, staff that are dehydrated do not carry out activity well, and we wanted to ensure that wasn't the case, and we looked after everyone to the best degree possible. So I wanted to also highlight what I think was a really important and guiding principle at Nightingale, and that was the role of the bedside learning coordinator. Andrew already touched on this, and I think this really positively impacted on delivering safe care and iterating where necessary. And that is the intentional building in of a reflective learning process into the fabric and the infrastructure of a hospital. And this was a way of gathering real-time shop floor intelligence about the shift and generating ideas and suggestions for improvement, highlighting any safety concerns where necessary, and critically feeding those into a daily meeting, which was at 4 o'clock. And this would identify which areas needed addressing and which areas needed changing as early as the next day, the following shift. And I think having this learning loop was really critical in ensuring that things that needed improving were improved and they were done in a timely manner. And as Andrew already stated, this was not an established hospital with agreed protocols and practices. It was put together in a number of weeks. And it was paramount to realise, and I think the executive team certainly did realise, that not all processes and pathways would have been correct at the start. And things needed to change and iterate along the way. And it was really important that there was this shallow hierarchy amongst the culture of staff, and therefore individuals were encouraged and actively listened to for their input. And this ensured rapid iteration and innovation on the fly effectively. And I think this really facilitated positive change with respect to patient safety and quality care for patients. Here are some examples of quality and learning impact. So identification of staff in PPE, as I've shown you, is clearly very difficult. And we employed use of these color-coded epaulets, which allowed us to identify staff in their different roles. So staff didn't carry bleeps, and so in order to identify them by their roles, we used these. So red, for example, was doctors trained in airway management, so predominantly anaesthetists and intensivists, whereas ward doctors would have a green stripe. Nursing staff would have different number of stripes depending on the level of critical care experience. And this really helped in rapid identification of individuals across a shift. Another was that the shifts themselves were overlapping. So we did 2 days followed by 2 nights and then had some rest days off. And by overlapping the shift, what that meant is that someone on the day shift or the night shift always knew what had happened from the previous shift, because essentially there was an overlap and therefore there was continuity of care. And this is really important in a rapidly changing environment like ITU, where it's important to understand the changes that have gone before to ensure that quality care is delivered and patient safety is really at the heart of that. And I think that was one of the successes actually. Another is the rapid iteration of training and induction, and Andrew already mentioned this. I think this was particularly successful and this needed a lot of change along the way. We developed a day 0 simulation and a shop floor learning program by the end as well. The O2 was used as a makeshift ward to ensure that staff were made comfortable with the environment, the equipment, and the training program really changed from the very beginning to when Nightingale closed 4 or 5 weeks later. And the reflections from staff that had been through it were really, really positive in saying that they felt much more comfortable with the equipment, with the protocols and the processes. And I think it was, again, a real testament to the incredible and committed training and education team that put this together and were able to change it along the way as was required. Another observation was that the Nightingale really provided a unique opportunity for learning. And I think we had an incredible number of individuals, but mainly from a non-ITU environment. So the beauty of that, whilst being able to be led and driven by intensivists, the ITU also benefited from having all these fantastic individuals who normally don't work on an ITU, but being able to deliver care in their expert way, improving the quality. So we had district nurses who were expert on skincare, for example, and they were able to provide unique input with respect to that. We had ophthalmologists, not usually found on an intensive care unit, guiding us on how to look after eye care. We had dentists who were recruited and they were giving us expert help on mouth care. All of these things really crucial in looking after the patient as a whole. We had gastroenterologists. Gut absorption is a key problem in intensive care, and they were able to give incredible input onto how to manage this more effectively. And indeed, orthopedic surgeons as well, also not usually found on an intensive care unit, giving expert opinions and help on musculoskeletal issues. So I think this is really just to show that whilst normally I think in the NHS we do work in silos a lot, as this diagram is supposed to demonstrate, actually this environment at Nightingale really provided an expertise that I think enhanced the quality of care of these patients. Finally, the family liaison and support team was a really important group of people, and I think it's important to mention them, and they really created an incredible environment where the clinicians on the shop floor were able to get on with the clinical role, knowing full well that the family liaison team were taking on this role. And they were made up by a group of clinicians and also voluntary experts and communicators from the Army Yeomanry Corps. And they were able to help update patients' families every day. We achieved ensuring that patients' relatives knew within 6 hours of them coming to the Nightingale. We ensured that the relatives had a daily update from us at the Nightingale, and the mean call duration was actually 27 minutes. So this wasn't a quick call, a quick update. This was a really extensive communication between our team at the Nightingale and patients' relatives. And I think this was really important because it allowed us to focus on our clinical roles. And we did this using standard telephony and also made use of tablets to stress the importance of non-verbal communication. One other really important and I think heartwarming story here is of the heart-to-heart story that we used at Nightingale. This was effectively a project whereby a small stitched heart was given to the patient and a similar crafted stitch heart sent to the relatives of the patient with this poem attached. This really allowed patients and their patients' relatives to be able to feel like they were with their relatives at all times. And the feedback we had from families was really fantastic. So from a personal perspective, in summary, it was a humbling experience to be part of an incredible team at the Nightingale. The challenging environment was clearly there, and the circumstances that we all faced were very strenuous. But we realised our team efforts for our singular purpose, which was to look after and save as many lives as is possible. And if I finally may just reflect on one story, I remember when the moment when a patient was extubated and wheeled down from the intensive care unit to the step down area across the hall. And without any planning or organisation, everyone spontaneously turned around to look at this patient, and there was a rapturous applause across the hall. And I think in that singular moment, everyone there realised our group purpose of coming together to save as many lives as possible. And finally, we were able to critically deliver compassionate care in a field hospital setting. And I think this was a really unique element to the fabric of the hospital, and I think is a success to be reflected on. So thank you very much for listening.
Thank you, Jonathan. Thank you for identifying some of the key key issues that you've reflected on and you remember and that stick in your mind. Some of them very practical, around working with colleagues from different specialties, some of them around technicalities, as you say, in terms of equipment, but the very personal ones are the ones that say the most, I think. And the family liaison was a key part for many organisations, and it's interesting to hear of the experience at the Nightingale, and as you say, families having perhaps seen their loved one go into one hospital, then to find them moved to another one about which little was known must have been particularly challenging to manage. So thank you for sharing that. I'm going to ask Joe Cade now, a registered adult nurse with 10 years experience. He's mainly worked at Guy's and St Thomas's in London, with specialising in plastics, head and neck and oncology. She's also worked overseas, linked to tropical diseases, and has special interest in airway management and tracheostomy. And she was part of the team both opening and closing the NHS Nightingale at Excel. So welcome, Joe, and please share your screen.
Thank you, Libby, and thank you for the invite as well. So yeah, like Libby says, I am a head and neck nurse at Guy's and St Thomas's Hospital, seconded for the duration of the opening at the Nightingale Hospital. I really want to just share some reflections and learning from my time there, focusing on one incident and the prominence of staff welfare and the wellbeing team as well. First of all, making care safe. Every nurse in the UK, we adhere to the NMC Code of Conduct, and the first principle in that code is prioritise people. We put our patients first, we make their care and safety our main concern and make sure their dignity is preserved, their needs are recognised, assessed and met. And I really feel like the Nightingale did that. We delivered compassionate and respectful care under the very challenging circumstances and unique environments. And it really was a very special multi-professional team. From all over the UK, we worked side by side, hand in hand, and it was really a cohesive team effort. And let's go to the next one. How did we make the Nightingale Hospital safe? Rapid opening, a whole new brand new workforce, a high risk intensive care environment. We developed a really robust training program, policies, pathways, protocols, and we had a clear mission, like Andrew mentioned, about saving lives, looking after staff and keeping good communication with the families. Now, measuring safety, traditionally we look at incidents, infection, for example, mortality, feedback and audits. So we had quite high incident reporting, 144 reported. And I think that demonstrates that the Nightingale really did well at building a no blame safety culture for resolution and learning. This system manifested itself and staff were really striving to make things better continually. We knew who to report to, how to escalate things. We were made aware of the DATEX system and how to use that. It was a real collaboration to support improvement constantly, almost like this sort of relentless dissatisfaction with the status quo, which is legitimate and necessary. So just a breakdown of the incidents by category here. Medical devices, that would include sort of suction and ventilators. Medication is the error. Are we talking about the incident? Pressure ulcers as well. We actually did recruit a tissue viability nurse to help with that, along with the district nurses. And the proning team were involved with the reduction of that. And some issues there also with staffing and communication as well. If we look at the incidents by date, we can see largely there is no harm caused. Some orange ones there with low harm and a few moderate harm. So the incident I'll talk about is an unrecognised hypoglycemic event. So a 62-year-old male, type 2 diabetic, receiving an NG feed with insulin infusion running. Now, the blood gas was taken around 10 AM, showed a blood glucose of 1.3. It was then transcribed onto the large paper chart, which we have at the bottom of the bed, and it read like a 7.3 because of the tip. Now, the blood sugar was then repeated. The gas was done at 4, and that showed a blood glucose of 1 or 0.6 on the forms. So why did this happen? Well, the use of paper charts does give rise to a degree of error. There was no bedside glucometers that were available, which staff are used to. There was a bit of a lack of clarity between the roles and who was really responsible for that blood result review. Some likely sort of insufficient training on diabetes and insulin management at the beginning of the training, although it's important to recognise that that did evolve. Safety systems were not quite fully embedded, and the shift that day was extremely busy with about 10 or 11 admissions, I think, on that time. So what have we learned and what are we doing about it? Well, it's important to look at this incident happened on the Friday after week 1 of opening, and all the staff were interviewed, the family were informed. The staff obviously a bit stressed and concerned at the start. However, they were so involved with the report and were able to see that before it went out. It's also important for me to say that there was no neurological damage caused to the patient from this incident. The positive is that it was a very responsive cycle, there was a rapid turnaround, and routine safety measures were put in place. So blood glucose monitoring is now 2 hourly. The modified insulin prescription and variable rate is attached to the drug chart. The blood gases are now signed and endorsed by an intensive care nurse or doctor. And I really feel like those intensive care nurses are supported with regular twice daily safety huddles. The ward rounds are now very structured. There's also a plan to switch to complete electronic records should we reopen for the next wave. Quality governance meetings were established, like we mentioned there, with the 4 o'clock daily meetings. Just a quick comparison then. I think it's good to look at our incidences compared to other departments which were well established, and obviously we were not. So the Nightingale Hospital there in orange, high incident reporting, but I think that demonstrates a culture where staff felt empowered and equipped to report, and we knew how to do that. Just brings me on to the next slide of the wellbeing team and staff welfare. Now, we know that improving the work environment can also improve the quality, and it liberates the safety of patient care. And I really feel we were able to do that because we were so well looked after. Our psychological PPE, if you like, was intact. So we were fortunate enough to have hotels on site, which we stayed in, hot meals provided, and even TfL provided transport with bus shuttles around the area. The wellbeing team were always visible and approachable. We had an outstanding sickness rate of 2%. James here from the wellbeing team. So he was some of the wellbeing team were from Virgin Atlantic. So he was from there. He sadly lost his job and came to work with us. Now, he always seemed to know what was going on, what we needed, and who to contact. He was really good at encouraging open conversations. He was based in the staff urban garden. So always approachable, just as you would don and doff, go to the toilet, he would be there with open arms to sort of have a really good open conversation. And that urban garden area was a really nice staff area. It was comfortable and a place where you could rest. In that urban garden area were all these beautiful messages from the children, from local schools, and also the top middle one there, you can see there's messages from family members. And that was really, really touching. It felt like the public were really rooting for us alongside the clapping. That was a really emotive thing to sort of read these on your breaks. Because, you know, looking after these COVID patients was tiring. You're constantly sort of racking your brains, scratching behind your ears and digging into the depths of your heart. So really grateful for these messages. Just a quick look at staff feedback. So staff were invited to share reflections. There were semi-structured interviews that took place. Really some common themes that popped up about the essence of feeling like you were one team, the collaborative working and learning that took place. And I think these figures indicate that our well-being was looked after. I felt safe, supported, physically able and mentally able. And I think there's some really good figures there. And 74% of us said the last shift was better than the one before. So that's good. So yeah, thank you. I've left a piece of my heart at the Nightingale, but I will definitely be taking away memories of a lifetime and also taking away excellent ways of working to then employ into my trust at Guy's. And it really was a success, outstanding collaboration. So thank you. And we'll move on now to some questions.
Thank you, Jo. Thank you for sharing some of the vital safety information, and in particular the serious incident around insulin, but also the very broad wellbeing programme, which, as we know, the patient safety begins and ends with the staff. So you need to look after the staff so that they can look after the patients. Now, I've noticed actually we have had a number of questions while the speaker's been talking, but the beauty of this system is that they can be responded to very promptly. So Andrew has been responding to a number of questions as they come up. We've got a couple of questions at the moment. Perhaps Andrew, Melanie Witherow, I find it outstanding you can interview, investigate, carry out duty of candour and share the report with staff in 48 hours. I hope appetite for investigation is a lasting legacy and commissioners are on board. Any comment in response to that?
So it's good that's recognised, and I think it was just for an example of the resource that we had to invest in our governance systems. And so I find that a lot of the time around a conventional SI investigation is not often the investigation, but it's actually managing the process. So once we'd stripped all that out and we had people who were prepared to give up a lot of their time to do a rapid investigation, we could deliver that. I think it would have been hard to make it sustainable. But I think one of the things is that, we don't often train people to be experts in clinical governance and incident investigation. And actually, we were lucky that we had experienced people who were ready and waiting to do these investigations. And I think a lot of organisations struggle to have the right expertise to do these investigations, not just quickly, but also to a high level. We often rely on staff stepping out of their normal role to do it. So I think for me, the learning is that you either need to train more of your staff to be more expert at these things, or recognise that you need to invest in a specific resource. So that's probably the main learning from that point.
Thank you. Jo and Jonathan, at the bedside, well, this is from Shakir, were any of you ever concerned that some patients might not be able to get equal levels of care or treatment due to staff, PPE or time limits?
So thank you for the question. I think actually I have to say I didn't have concerns about that. I think that we were fortunate that at the beginning the ramping up of Nightingale meant that there were quite a large number of individuals at the bedside from the get-go. And actually the beauty of what was done was that we had staff shadowing other staff, so that what happened was we were expecting there to be one ward after another ward after another ward because of the expansion in numbers. And so at the beginning, we actually had quite a large number of clinicians at the bedside. So there wasn't any particular concern about not having enough. Now, of course, if we had opened, as Andrew said, to that large number of over 3,000, then it may have been more challenging due to the ratios and the numbers. I think that's for sure. It would have been challenging, but I think that the process that began at the beginning and allowing that handover and shadowing of individuals meant that there wasn't any particular concerns with respect to cover and ensuring enough individuals were on the shop floor.
Thank you. Jo, anything from a nursing perspective about that?
Yeah, I think what was good is, from a nursing point of view, was above the bedside you would have colour codes. So some patients would have a red, amber or green marking, and that would just be a clear indicator of you know, how sick they were, and it was a really good way of enveloping that into the handovers, and it was really fair that your nursing to patient ratio was safe, and you might just have one sick patient, for example, or you would have a couple of patients that were more stable. So yeah, there were definitely ways of working around that.
Thank you. A couple of questions about how it would be possible to share the very positive things, many of which you've highlighted today in your talks, the things that you learnt from Nightingale. How do you think those can be filtered back into normal NHS operations? How, other than through webinars, is there a sort of formal process to spread and share some of the fabulous initiatives that you've described today?
The various teams at the Nightingale that did different initiatives are all writing their experience and processes up. So, for example, our learning system, which we're really proud of, which was actually how do you, rather than having kind of quality improvement as an appendage on your organisational structure, how do you embed it right at the heart of a hospital and use all of the data flows that you get being properly used, not any differently than you conventionally would, but make it much more real time so that you can learn quicker, change faster, and constantly improve. So that is impressive, well, about to go into press. So hopefully there'll be an opportunity for people to read in more detail about what we've done, and that will also going to write up our outcomes. However, again, it's really important to emphasize, I'm fairly certain that probably 90% of what we did was also done in every NHS hospital. And I know in my trust, we've already started organising kind of capturing the learning workshops because you don't want to over exaggerate the learning, because it was a very unique situation. It might not be sustainable. It might actually create other unsafe issues if you try to recreate it, you know, for continuous work. But I think it's important to work out what is generally transferable. So hopefully every hospital will do that, and actually there are good networks for sharing information that have been set up that can, with platforms like this, continue to share the learning of all organisations across the NHS.
Thank you. An important question here, which I don't think is unique to Nightingale, but would be interested to hear any comments. Jonathan, you talked about difficulties with communication in PPE, but specific issues around people with hearing disabilities and PPE. Any thoughts on that? As I say, not specific to Nightingale necessarily, but
well, that indeed does sound like a challenge. I would imagine that one could envisage a system with extra speaker and sound support, that one, you know, you'd have to strap that to your gown. I'm sure there'd be workarounds. I think what not so much Nightingale, but actually just COVID has taught us within the NHS is that when you come across a problem, so many different solutions come to mind, and when you put your heads together, it's possible to come up with those solutions. And I think you know, that would be one of my suggestions as to how to deal with that.
Thank you. And then I'm going to make this our last question because we're coming up to 1 o'clock. So from Kenny Ajay, thank you. You describe excellent staff wellbeing initiatives during the peak of the pandemic. How about post-peak? How did step down happen? How are staff being followed up who were working in the Nightingale with regard in relation to sort of well-being and mental health? Is there a process for that?
My wellbeing team may be able to correct me differently, but I'm not aware of actually whether we've got a formal process of being able to continue that work. Unfortunately, everyone working there has now gone back to their previous roles and employment for whatever they were. But it's a very good point. We were very aware of the potential long-term harm of working in a very difficult environment. I think actually from all the reflections we've got, that we've not sensed that, you know, that there's been a risk of individuals having potential long-term psychological harm. And I think hopefully that was because of all of the preemptive things that we did that, you know, Johanna kind of described and emphasized. And certainly all the feedback we've had would support that. So although I'm not aware of any specific long-term follow-up offers are available, hopefully the need of those has been mitigated by the kind of preemptive work that we invested in.
Thank you very much. So on that note, I'm going to say thank you to all our speakers, Andrew, Jonathan, Joe, for sharing your insights and reflections on your experience at London Nightingale. Thank you to our audience also for joining this event and for your questions. Please do watch out for future patient safety webinars through the RSM. I should say at this point, there's an earlier interview with Charles Knight, who was the CEO of the Nightingale, on the RSM COVID-19 series. It's number 8. It was recorded on the 28th of April, and it's on YouTube if you want to look at that. And that certainly may address some of the other questions that we heard about use of the Nightingale in future. So if you haven't watched that, then I do commend it to you. Finally, thank you to the RSM team, Mariam, Judah and Maddie, for events management, organisation and AV support. Goodbye.